In this presentation, a subcapital fracture of the distal ulna with diaphyseal comminution and a styloid fracture will be treated with a 2.0 LCP distal ulnar plate. The objectives of this exercise are to identify the clinical indication for a distal ulnar plate, to show the principles of the distal ulnar plate, the patient position and the approach, the instruments needed, and reduction and fixation of the fracture. This clinical example shows a displaced distal ulnar fracture that will be fixed with a 2.0 LCP distal ulnar plate. The distal ulnar plate is anatomically pre-contoured and has pointed hooks to grip the styloid process and to act as a reference point for plate application. The plate accepts 2 mm locking screws, 2 mm Cortex screws, and as an option, 1.5 mm Cortex screws. The intercrossing 2 mm locking screws securely hold the ulnar head. The oblong plate holes accept 2 mm Cortex screws for ulnar length adjustment. The shaft contains LCP combi holes that accept either 2 mm locking or Cortex screws. The undercut helps to ensure that the threaded holes will not be distorted with typical contouring. The landmarks, which are usually easy to palpate, are marked. Here is the ulnar styloid. Here is the ulnar shaft. Here is the ulnar head. And here the extensor carpi ulnaris tendon. It is recommended to make a lazy S incision so that the scar is not where you would rest your arm on a surface. The subcutaneous tissue is dissected first. A skin flap is developed towards pulmar. Here is the ulnar head and the extensor carpi ulnaris tendon. Now the approach is between the extensor and the flexor carpi ulnaris. The retinaculum is divided distally. This is the ulnar shaft. This is where the fracture is. Now dissect distally up to the ulnar styloid. This is the styloid. Here is the bony groove where the extensor carpi ulnaris tendon lies. Here is the styloid, and here is the fracture zone. This is where the hooks of the plate are positioned. At the end of the procedure, the retinaculum is sutured over the extensor carpi ulnaris tendon. The instruments needed are the threaded 2.0 LCP drill sleeve, the 2.0 universal drill sleeve, the 1.5 mm drill bit, the depth gauge, and the short star drive screwdriver shaft with handle. For this exercise, the bone model is secured in this position. The ulnar styloid and shaft are palpated to plan the incision. A straight incision is made along the length of the distal ulna. The retinaculum is incised. The retinaculum is retracted along with the dorsal sensory branch of the ulnar nerve. This is the styloid fracture. Here is the subcapital fracture of the distal ulna with diaphyseal comminution and the ulnar shaft. The plate is positioned on the bone with the threaded 2.0 LCP drill sleeve. The hooks of the plate should be secured around the tip of the styloid. The 2 mm drill bit is used to create the screw hole. The depth of the hole can be read from the scale on the sleeve and the mark on the drill, in this case 20 mm. The drill sleeve is removed and a 2 mm locking screw of appropriate length is inserted with the short star drive screwdriver shaft with handle and fully tightened. The ulnar shaft is held with the pointed reduction forceps and the ulnar head is reduced to the shaft. The 2.0 universal drill sleeve is inserted into the oval plate hole in a neutral position, and a 1.5 mm screw hole is created. The depth is measured. A 2 mm cortex screw of appropriate length is inserted and fully tightened. The comminution zone is now bridged with the plate. Any fragments in this zone are left with their soft tissue attachments and are not fixed, to promote healing. At this stage, it is important to check the reduction and the placement of the plate under image intensification before continuing with plate fixation. 2 locking head screws are inserted through the most proximal plate holes. A 2 mm cortex screw is inserted on the other side of the fracture line and fully tightened to bring the bone to the plate. A 2 mm locking screw is inserted in the second-most distal plate hole to increase stability of the ulnar head fragment. The clinical post-operative X-rays show good reduction and correct positioning of the plate. This presentation has shown the clinical indications for a distal ulnar plate, the principles of the distal ulnar plate, the patient position and the approach, the instruments needed, and reduction and fixation of the fracture.